just share a little bit about myself before we start this kind of intensive, amount of information that I've crammed into here for you. But I wanted to start to tell you about me personally a little bit, my story, and why I am so involved in the Down syndrome community. The Down syndrome population community really grasped me from a very young age. I had an SDC classroom in my elementary school, and so I found myself wandering in there and volunteering. And what I didn't realize way back then when I first met all those children was that those children were really molding my life. And so I am really here today because of the experiences that I was given with children with special needs very early on. And if that's not like the biggest toast to inclusion, I don't know what is, right? So growing up, I was volunteering with Challenger Baseball, which probably many of you know. I spent a lot of my junior high and high school weekends with Challenger Baseball, and it is there where I met the founder of the Down Syndrome Connection, Martha Hogan. And the Down Syndrome Connection, if you don't know, we are a philanthropic organization in Danville. We've been there since the 90s. Martha's son Blair is 1 year older than me, so Blair and I grew up together. And she founded that organization based on the fact that she really needed support. And so when she was able to find some support and then grab a whole bunch of families and start in her home, and now it's grown bigger and bigger. So I actually have an office space inside the Down Syndrome Connection of the Bay Area where I see clients and children. So growing up with children with special needs has really given me this opportunity now to be here in front of you, and I am forever grateful. And in doing so, I have found my niche area and my specialty that I love so much, and I'm just really here to share it with you today. And I'm here because of my passion, and I'm here because of my love, and I'm here because I'm just really trying to reach out. Part of my professional and personal goals is to try to reach out and educate parents, professionals, medical staff, you name it, everybody needs it, and you know it, right, as parents, because you feel like you're always educating everybody that you meet about your child. And we know that, and so that's why we are implementing so many programs to try to educate educators, right? We have a program with DSC that's doing that right now. And so as part of this, I am here and I am trying to educate you. I also run education programs for speech pathologists. The stuff that I'm here to talk to you tonight is just not very well spread, and so me training other speech pathologists is so much part of the plan. And so if you have other speech therapists that you're working with from school, private, anything, who you would like more information, send them my way. We can get a group together and we can get another training going. It will just only benefit more kids, right? Because the more people that are trained, the better off we are. So I have been a speech pathologist for 12 years. I've worked exclusively with children with Down syndrome for 7. And to be a speech pathologist, you have to have a master's degree, and I got mine at Gallaudet University, which is a school for the deaf in Washington, D.C. So I have a signing background, and you'll probably see that as I use my hands a lot. But, a lot of speech therapists probably do that. So I work at the Down Syndrome Connection a few days a week. I also work here in the Silicon Valley 1 day a week. That's Thursdays. That's why we're here tonight. And then in the city. I really want to talk to you a little bit about how I found this area, this niche area, and how important it is. And then I'll really get into all the details and we'll do the teaching. But working at the Connection, we have lots of family events, kind of like you guys do here. And we had a fire safety day. And I had just started practicing there, and what had happened was I was kind of seeing a few children, and I was doing kind of general therapy, like a lot of people do, language, speech, you name it, it's all mixed together. And so I went to this fire safety day on one of the weekends, and I started talking to parents and seeing children and noticing that the lunch that they brought in was so awesome. It was barbecue brisket and steak and vegetables and fruits and this great spread. And on our kids' plates was like crackers, chips, bread, juice. And like that was it. And it was just soft or it was crunchy, and that was about it. And so I just kind of thought back and I was thinking, gosh, cannot be a coincidence, you know? All these kids, and as I asked parents are kind of attributing it to, oh, he just doesn't really like vegetables, or he doesn't really like fruits, or not really meats, and I'm just thinking, this is so not a coincidence. And I'm thinking back to this video I saw through the Down syndrome organization in Northern Virginia when I lived there, and it was a Talk Tools video. And the creator of Talk Tools is Sarah Rosenfeld Johnson, and she had given this 2-day presentation about speech intelligibility and feeding and how your oral function for speech and feeding so goes together. And so it brought me back to that video, and I thought, oh my gosh, I have to go back and I have to order all those videos, and that's what I did, and that started my obsessive compulsive nature about oral placement therapy and what we're going to talk about tonight. But you know, when you really find something that works, I mean, you just use it, and the more I used it, the more clients I got, and the more kids that were using it, and they were getting better, and their speech was getting better, and their feeding was normalizing, and their faces looked great, and they had these great smiles, tongue in, lips closed, and it was just like incredible to me. And so that is why I'm up here tonight, because of starting with the kids, right, at special day class, and all the way through all of my experiences with these children, and up until that fire safety day, which really put me into where I am today. And you know, a lot of people don't know about Talk Tools, they don't know about what we're going to talk about tonight, because unfortunately the training for it is really in depth. And so you not only do you have to kind of take in all of this information, but you have to do it over long periods of time. So you watch all of these different videos, and then once you get all those in, you have all this information, you kind of don't know how to apply it. So then you ask the company, I need more information. And they say, okay, well, Sarah will come out and train you. And so Sarah comes out and sees 20 children with you, and you do these personal one-on-one evaluations. So after you do that, and she makes you cry like a few times, you write all these reports, and she passes you, you know, after you know, fires her a little bit. And so, you know, it's a big process. It takes a lot of time. It takes a lot of time, a lot of money, and it takes the caseload, you know, behind it. You have to be working with all these children that have oral functioning issues to be able, you know, to want to go through this process. So after you go through a process like that, then you have a level 3 certification. And that's when they put you on the website and they say, okay, this is a provider that is trained in Talk Tools. They have different levels, up to 6. So right now I have a 4, level 4 specific to Down syndrome. And so that means another year went by, she came out again, you know, whatever out of me, and taught me some more. And at that point, that's when I really felt very comfortable in what I was doing. And then it's been maybe 2 or 3 years now, and I've decided, okay, I'm going to start presenting and giving information now, and passing it along and training other people. So the process is pretty, there's a lot of information, it's really in depth. And so we're going to talk about tonight. It just might be a lot. I hope I give it to you in a way that is understandable. Don't be surprised if you go home and you forget everything and you totally black out. But just take a few things from this, and I'll tell you which things to take. And then use me as a resource. So my information's all in here. I can always evaluate your children. I can always be a reference or a resource over the phone, help you and your speech pathologist. Whatever you need me for, I'm around, because that's a personal and professional mission that I have, to reach as many people as possible. So your course objectives today, the main thing I really want you to understand is how strength, stability, tone, and sensation really affect your child's oral functioning for speech and for feeding. I want to touch a little bit on feeding development. I think that's really important, and I want to demonstrate some techniques with some of my tools. And then I want to have open forums. So the open forum can come during the talk. If you'd like to ask questions during the talk, that's kind of actually more natural. So when you do have a question, please let me know and we can address it. It can be about your child, and if it gets too in-depth, we can talk offline, but a lot of people probably have the same questions. And then I just really want you to leave the class feeling more empowered and feeling that you can use me and spread more information and wealth across your community. I want to just raise a hands up with parents in here. Is everyone a parent in here? Okay, and then what about babies 0 to 1? Okay, 2 to 5? Okay. And then elementary school? Good. And then junior high? Okay. Okay, and high school? Oh yeah, okay, you're on the cusp. And then adult? Okay, nice. The last talk I was just at in the Central Valley, we had, they have an adult advocate on the board, and so the board was the one who put on the talk, and so she sat right next to me, and during the presentation, she asked me all these questions, and it was pretty awesome. Okay, so are there any professionals in here? I'm sorry to ask. Okay, so when we talk about children with Down syndrome, and maybe all of you already know this, but you kind of look at a child. If I'm going to talk about a child generally, I'm going to talk about them as having low tone, low strength, low sensitivity, and we're going to go into all of those. But it's important to know the difference between tone and strength. And low muscle tone is something that you are born with, and it does not change, and you will always have it. So if you think about a child who has high tone, they would have a lot of tension, right, in their muscles. And it is the amount of tension in your muscles that defines tone. So maybe someone with high tone is like this. We have normalized tone, and a child with low tone, right, looks kind of like this, especially as a baby, you know? We have a lot of floppy, very flexible children, right? And a lot of our kids as babies don't walk till later, 18 months, 2, 3, 4, right? So low tone is something that never changes, but it is something that we can counteract by using strength exercises and stability exercises, and that's very important. And that's why all of you do PT, right? And that's why PT is like the first thing you're given in early intervention, to start working on your child's body so that they can start using all of their body for functional tasks. We see low tone in so many areas, and they're listed here, and there's so many more, but we will move on from here and talk about strength. So strength can be changed, right? You can go to the gym, you can get stronger. You can go for 3 months and you can become buff, right? Your child can do that too. And strength can counteract tone, and that's really important. So whenever you're working with professionals, if someone says to you, oh, I'm sorry, we can't do oral motor, we can't do something like this, because you can't change tone. And you can say, I know, but you can change strength and you can change stability. And that's very important for you to be empowered to know. So strength and tone, this is Chelsea. She lives in the Danville area, in the East Bay, and she's awesome. And Chelsea is one of my clients, and she is a international Special Olympian gymnast. And she wins all of it. And she lives right here, and she's so awesome, you know? And if you meet her, I mean, this is one of her pictures, right, from like Tokyo, or like wherever she is, you know? And if you meet her, she's incredible. You see her and she does flips across the floor. I mean, if you turn on the TV and you think of a gymnast, that's her. That's exactly what she does. Like, there's nothing, you know, she has no impairments in gymnastics. She does the beam, the bars, the floor, all of it. And she is like the ultimate testimony to me about strength and motor planning versus tone. Because she has such low tone. And if that's not a testimony, then I don't know what is. And when she walked in the door, and I met her, and no one had ever worked on her face before, but her body looked like that, I was floored. Because she has, at 18, unintelligible speech, but she can do flips across the floor. So she's such a testimony herself to, I can do it with discipline, I can motor plan, create stability, create strength in my body to do these amazing things. Of course you can do that in your mouth as well, but no one ever did that for her. So she came in with the mouth of, I don't know, 1-year-old, 2-year-old, and you know, she has been trying to talk for 18 years, and that's not fair. And so, unfortunately, I was brought in as an IEE, right, an independent educational assessment, and so we took the speech therapy out of school, and then they gave it to me, and then we've been working for 3 years, and now she has great oral functioning, right? She has tongue movement, she has lip movement, she makes her sounds appropriately, and she's using phrases and sentences, and she goes out on dates, and she orders food. I mean, it's functional, right? And that's all we want is independence, right? And inclusion. Independence and inclusion. That is all we want for our kids. I forgot to say this earlier, but I always say our kids. And I don't have a child with Down syndrome, but I have so many adopted children with Down syndrome, right? I mean, families, children, we are a community, and so I hope that is not offensive to you when I use that, our kids. It seems more personal to me than like children with Down. It's like, they versus us. So Chelsea is the ultimate testimony, I think. And I want you to look at her because she's so strong. She has these amazing biceps, this trim, lean muscle mass, but then she sits in a chair and she still has this pelvic tilt and all of this kind of stuff. And so this is tone versus strength, just to make that really clear. Does anyone have any questions? So if you generally, again, look at our kids and you think low tone, low strength, low sensitivity, and hyposensitivity is really what I'm talking about right now. It's an underreaction to tactile input. And you think about it as the Novocaine effect in your child's mouth. So if you go to the dentist and you get Novocaine, would you leave and would you drink coffee? No. Would you leave and would you eat an apple? No. And why would you not do that? Because if you drank your coffee, your lips might part and it might spill all over your outfit. If you go to chew, right, you could bite your lip or your cheek, and maybe you've done this. Yeah, exactly. The next time you get dental work, actually, it's really interesting because you start comparing to your kids. And I've done that, driving to work from the dentist, like, oh my gosh, I can't believe how I feel. I can't believe how this feels. And if you think about low tone, low strength, and low sensitivity all going together, and then you're like, why can't my child eat? Why can't my child breastfeed? Well, oh my gosh, because they can't feel what they're doing. Why is my child not making the right sounds with their lips? Well, has anyone ever thought they can't feel their lips? And so sensory is such a big part of this therapy technique. Sensory motor, they go together. Because when you go to the dentist and your sensation is impaired, then your motor skills are impaired. And so, and you have fine tone and you have great strength. And then think about your kids who have low tone, low strength, and low sensitivity. It's not fair. It's this huge cocktail. And so when you're asking them to repeat me, do what I say, watch this, and they're like, Mom, I can't feel. I have no idea what I'm doing right now. That's not fair. And that's why infants, right, they feed on bottles better than they feed on mom because it's rubber and they can feel it more. Or nipple shields, right? Or this is why a lot of our kids like tastier, spicier, like barbecue sauce and crunchy things because they give more input. A lot of babies, when they come to me, mom says, well, he won't eat any of this baby food, but he eats my Indian food. And it's like, well, yeah, because he can feel it, right? And so you like garlic hummus, he totally takes it down, but mashed bananas doesn't work, it's like add something to it. And so all these components are so interesting, I think, but they just, the second you add ice to your baby's food, oh, I can feel it's in my mouth. I mean, I have so many kids that plop them down, first spoon feedings, I don't know why it's not going anywhere, and you just put the spoon in the baby's mouth, and you can tell the baby has no idea that there's food in their mouth. And then you put ice in it, and you freeze it up a little bit, and you feed them, and they go, and they can feel it, and they manage better. So when you can feel something, then your motor system works better, and that's such a big part of this. a lot of our kids are in that tactile hyposensitivity range, but some of our kids are also here in this mixed sensitivity range. These are our kids that a lot of times have apraxia of speech. They are kids who perhaps have a combo of sensation. So perhaps low sensitivity here, but normalized sensitivity on the tongue and palate. So like cheeks and lips can't feel a thing, but palate and tongue totally can feel. So you put food in their mouth and they're like, that tastes good. Oh wait, where'd it go? Oh, it's gone. Where'd it go? Oh, it's in my cheek, but I don't really know that. And then 2 minutes later, oh, there it comes back. I choke on it. And so it's very confusing. So these kids tend to go, no thanks, I'm not eating mixed textures. So if your baby is going from purees and bottles to not having a hard time getting on mixed textures, a lot of times we see something like that. And what we see there is tactile defensiveness. That's like, no mom, I'm smarter than you, I can't handle that, I don't process this right, I need some help, so, And we see that all the time. This tactile defensiveness can also happen with hyposensitivity as well, where you're just like, mom can't feel anything, not choosing to eat anything with mixed textures. And the mixed textures like soup with chunks and broth, yogurt with chunks, right? How many people have kids who spit out the chunks of food, right? Or then how many people have kids who don't and they just swallow the whole thing and like don't chew anything and just swallow everything, you know? So it just really is a testimony to to what your child can or can't feel. Hypersensitivity we don't see a lot in our population. So if by chance you have a hypersensitive diagnosis and you don't have autism, then perhaps it's tactile defensiveness and it's just a maybe confused diagnosis. Fluctuating tactile sensitivity is something I don't really see very often either. And it is something that it is where the child literally feels one thing 1 minute, 2 minutes later feels another way, 2 minutes later feels another way. I have a child with CP right now. Vibration in the mouth, 5 minutes later vibration again, big tears. And that's a fluctuating system. And that's a tough system. Does anyone have any questions on this? You know something I forgot to say to you, and I meant to say to you in my introduction, is that I'm speaking from clinical experience. I totally don't claim to know everything, totally. And so I'm here today to share what I think, what I believe, and what I know has worked in the past 12 years for me. So if you have anything else that works for you, tell us, tell me. I want this to be so collaborative. So talk, smile, you wave, yes.
What would it be when sometimes they can eat and process technical problems with the textures, and other times it's like, random, all of a sudden it's like a foreign object in their mouth, and they're like that, like they don't even want to completely chew to swallow, like all of a sudden it's like a foreign object in their mouth. My son has gone through he's 13, he's gone through the years of having different fluctuations like that. And then sometimes he'll just wolf it down. Is it too fast? So you have to like kind of guard. But he has a dual Downs and autism, not just so I don't know, but you never know quite what to say about it when people ask questions, because sometimes it's this way and sometimes you may eat yogurt and it's got any chunks in it. He loves the yogurt, but he'll get rid of the blueberries or other times he'll eat it and like no problem.
Really?
Yeah,
in true form.
Like sometimes he'll chew meat and he'll eat a hamburger, he'll eat chicken, no problem. Other times you might give it to him and he'll have like just a foreign object, like what he's not gonna. And I don't know what that's
interesting. That is really interesting. I would probably want to like look into his background a little bit more, because I mean either that's kind of a fluctuating, or perhaps based on illness. Like if the more congestion you have, the more taste buds you kind of lose, and sometimes when you're sick you can eat better than or not as when you're not sick.
I used to read it like he just got tired of wanting to chew and swallow it. Like it took him a while to chew it, and like he didn't want to swallow it, so then he just wouldn't swallow it. He chewed it enough to swallow. I don't know if it was a fear of, I don't know.
That's really interesting.
I don't know what to make of it.
No, I don't. I would have to look at him to actually tell you, but that's an interesting one. I don't know from off the top of my head.
I would say that my son has that too. He's only 3.5.
Okay.
But I'm a horrible mom, right? So I let him watch Peppa Pig during dinner And when he's watching TV, like, he's just eating. And he eats good, and he'll eat new things, and he doesn't have any and if he's engaged in something while he's eating, then that's when he's like, no blueberries, no this, no that. So he changes a little bit too. He loves like Quaker oat granola bars, so he loves texture, but he doesn't like blueberries, not blueberries, you know. So he fluctuates, I'd say, every couple of days.
I thought it was the blueberries, but I gave mine fresh blueberries, he loved it. By itself. Maybe we get some extra.
You know, sometimes when children have to watch something to eat, it signals some sensory, like kind of a larger sensory component behind what's going on. Do you have an occupational therapist that's working on some of that?
I mean, he has an OT at school.
Yeah, but that's not.
Yeah.
Yeah.
But I'm just saying he's like open to a lot of new things when he's
That's
watching.
Of course, because it's distraction.
Yeah.
Absolutely. And usually those kids have like a deeper sensory root, or, you know, we need to look and see what's going on in his mouth. And that could be a mixed type of profile right there. I mean, the TV is definitely a way I know a lot of parents get a lot of things in. You know, that's hard, but thank God, but you know.
I don't know.
Yeah, no one's judging, that's for sure.
This one comes from my daughter, she was used to get the baby,
Yeah.
but when she eats oranges, like when it comes to taking the juice, she can't swallow it, like she just spit it out.
She spits all the skin out.
All this is out. Like he doesn't like that they kind of chew and just try to swallow it, then the thing is coming out.
Is the juice coming out too?
No, everything is going out, like in the chin part, like, but any other things, for example, like either she can eat bread or anything else, like that on his head.
Yeah. I think, I mean, if she's okay with eating so many things, I mean, is she eating nuts and like beef and steak?
And then mostly vegetarian, like chicken she eats, fish rolls.
Yeah, she's pretty easy.
Yeah.
You know, oranges are actually particularly hard and stringy, you know, you can kind of put them in the celery, you know, kind of area, where you have like those strings that are really hard to chew through, and if you don't have really great chewing skills, then oranges would be a harder thing to chew. Try it.
I know the fruit is from all
With skin and everything. It's interesting. I know. Yeah, you should, we could, you know, you could look at her and see, but I mean, if it's one food, it's probably not quite an issue you need to deal with. If it's a huge group of foods, then it's more of an issue. That are harder. I would think like meats, like beef, like any non-processed meats. I'd also really look at her chewing skills, and we'll talk about that, but at her chewing skills, and if she's really chewing foods to the max. Because a lot of our kids actually don't chew their foods very well. They take a few bites and swallow.
That's almost like also, but this one
Yeah.
they could chew.
Well, this is probably a pretty scary one, I would think, and that's why she's spitting it out. She's smart. Yeah, she's protecting herself. That's a pretty scary choking. For her. Yes.
So I have a question, how does the other senses come into play? So, you know, we hear about the TV example. So my question is, in terms of child's senses all coming together, in terms of, you know, sometimes we're guilty of it because it makes see something that she really likes. So she gets a visual of something that she really likes. She takes the bite, but it's not what she saw, but she'll eat it anyway. So I'm beginning, you know, I wonder how much all the other senses combined, like, you know, does that have an effect in the learning process, just as it does with everybody else, right?
Give me another example.
Just give you an example myself. I mean, drinking out of the bottle versus drinking wine out of the bottle versus drinking wine out of the glass. Because I have the nose and the taste, obviously it's a different sensation than drinking beer or something out of the bottle. I get that. I pick that up. from her, from her child, where other senses are coming to play, and this risk and reward of this pleasure comes into play when other senses are involved. So, I guess my question is, should we subconsciously try to bring other senses into this as we teach her to like something or eat something, to put stimulation around visual, hearing, and everything else associated with it? I'm just guessing. I don't know if that makes sense or not.
I mean, I would say yes. I would think that the experience of learning, you know, what food is, smells like, tastes like, feels like, all of those things is important for any child. Let's see, what was I going to say about that? And it's very big for trust. You know, so many of our kids have trust. They don't trust us when we hide things in their food. And so, I don't know why. But trust is such a big issue when your child knows what they can manage and you're trying to slide in a few things, and then after that they're like, no thanks, I'm not eating from dad anymore, you know. And so trust is a big issue, right? I'm sorry if I didn't answer you. Okay, all right, yes.
So I never heard about you were talking about the ice with the temperature.
Yeah.
My son will not eat anything unless it is super cold out of the fridge. And I've been to 2 different OTs, and no one ever mentioned that could be what it was. It was sensory. He seems to have the tactile foods in this. He's going to be 3 soon, and he is still eating pureed foods. And we have tried until we're blue in the face to get him to eat solids. We've had all of our friends and family tell us everything we're doing wrong, you know, and we are, you know, oh, we'll just leave it there, he'll eat it eventually. We've had 2 OTs tell us we have to wait until cognitively he understands rewards, because the only way we're ever going to get him to actually eat is by doing that. But he does exactly what you were talking about. He has started recently in the last few months to get a little bit more adventurous, and he literally will chew it up. He's got all his teeth. He knows how to chew. He will chew it completely up to the point where it's okay to swallow, and he tries to swallow it, and he vomits. Like it's total gag reflex.
Her son was just like that too.
Yeah, so it's all pureed foods, and it's all gotta be in a cooler bag and as cold as possible. Everywhere we go, and it's, you know, I don't care what other people think, but when we go to restaurants, it sure would be nice if we could just order some food for him. Oh, and his other thing is he will only eat canned green beans and canned peas. If I make it anything fresh, he won't eat it, and he will not eat any other vegetable. And he'll eat meat, like he'll eat I grind up steak for him, I grind up chicken for him, peas and green beans, but it's literally the same every day. And you try to give him something different, and he won't eat anything for the rest of the day. So, I mean, is that just pickiness? Is my family right? And they're like, oh, he's just being picky, you gotta keep that. He's tiny, I can't afford him to lose any more weight, so I just keep it. Yeah.
No, in my experience, I would really look at his chewing. I mean, I would want to look at his chewing to see what's going on. I'd want to look at his sensation in his mouth to see what's going on. I mean, he has a very big trust issue, right, with you at this point.
Because he's gotten sick so many times from typhoid.
Absolutely. And you know, kids don't eat like we do, you know, for fun, you know. They eat because, you know, they have to, right? They'd rather play. So, you know, if there has been some pretty negative
He's
experience.
actually very good at eating, but it has to be pureed. He eats like 2 cans of veggies a day. I mean, he eats a ton of food, and he asks for food, but it's got to be that food.
I understand. We have a lot of families like that. Something I wanted to tell you was a lot of times what happens is I get kids like that and we start them on a program that does not include food. And anyone in here that I've worked with has been like that, but it does not include food. We work for a while and it starts desensitizing the experience and it starts building the oral functioning necessary for the skill to eat. And slowly the child starts to trust, and we get it in daycare, they try to cupcake, you know, we get it in somewhere, and then we just scaffold from there. But it is a process that you have to look at the functioning of his mouth first.
I know he can eat other things. If he's with his friends, his friend, he eats ice cream with her. He won't eat cheese with her, but he'll eat ice cream with her, you know, so he will eat other things, but it's really rare. So is it something that it can't be taught then? I mean,
Absolutely. Children,
everyone keeps telling me I just have to wait.
I would
do
really,
something
I
about
would look at his mouth. I would do have a full evaluation of his mouth, absolutely. You can't just sit on that. Yeah.
Our son, when he was smaller, he was eating all kinds of fruits and vegetables, and then his tonsils got really big, so he couldn't kind of swallow, so we kind of stopped, and then he got the A&T surgery, and after that, he won't eat fruits.
So maybe his taste buds kind of changed.
He will eat the vegetables, but the fruits, and he ate strawberries, grapes, everything. And now papaya, everything, he ate everything before, and then afterwards, I can't get him to even put in his mouth.
Children definitely have taste preferences. I mean, when you have like a tonsil and adenoid surgery, you have it because you had a lot of infection in your body, right? And when you have a lot of infection in your body, your taste buds are often changed. So I mean, perhaps he wasn't tasting a lot before, and now his taste has changed, and he's actually tasting, you know, what it was meant to
But he don't
taste.
even want to try it. He don't want to even in his mouth.
Right. I think there are ways in which to present things very slowly to get him to try things. I think there are a lot of ways that we could look into that. It might just be, some kids just like salty versus sweet. Some kids do, some people do, right? But there are definitely ways to present things to him.
You could actually eat chips all day.
Yeah,
He
something
loves
like that.
the
He's not
salty
gonna
and
eat
the
chips. So if he's sick, if he's ill, and he's not eating, we'll get a bag of chips and he'll eat.
I get it.
Veggie chips.
Yeah.
any
kind of
chips,
chips, any kind
Can
of
you
chips.
get in veggie chips?
Yeah.
We have
Like,
to.
can you get in those freeze-dried vegetables, like you get it like Trader Joe's or?
No, but you know, like if I give him carrot sticks, he'll eat that. But it's fruits or cucumber, he'll eat that.
Yeah.
I mean, he's eating
It's
junk.
like anything
Yeah,
is
exactly.
crunchy, anything is
Try the
crunchy.
dried fruit that's
Yeah.
crunchy.
I try it.
You won't eat
Can
it?
you mix that? Can you mix that crunchy dried fruit with your crunchy vegetables and just see? There are ways. I mean, try that. Anybody else? So before we get into this, we have to look at Gretel. She's so cute. So cute. And her name is Gretel. And her mom makes all of her hair bows. So there are 6 structures that comprise speech, right? And if you have to just think of them and just remember them, it's not just your tongue, it's not just your lips, it's your cheeks, your velum, which is at the back of your throat that lets your air either through your nose or out your mouth, your jaw, your abdomen, and your lips. So if you were to guess which one was most important for speech clarity, which would you guess? Which one? Abdomen. You were? Yes! You've been at more sessions than you have. It is the jaw. The jaw is so important. Your jaw is like your foundation for all of speech clarity. If you compare your jaw to your abdomen, it is, you know how your abdomen, your core, you go to PT, you work on it, and you work hard, right? You roll over and you do all those little baby things, right? And you have to be strong enough to be able to move your legs and then to move your arms, right? We have a little boy right now who will wave when his mom goes like this, I'll go like, it's like so cute, but he doesn't have the strength to hold up his arm yet, right? So when you hold it up, his fingers work. There's no impairment in his hands or anything. It's just that he doesn't have the strength to hold him up yet. So your jaw is like your core. So when you're looking at your child's mouth, if you have jaw instability, then that is the first place you go to. And if you take nothing from tonight, take that hyposensitivity and take the jaw. And then you will start seeing your child differently. And when people say, oh, let's work on the tongue, you're like, whoa, let's work on the jaw. And then we'll work on the tongue and everything else. Because you can't work on anything else if you're not targeting the jaw.
So that movement that the Down syndrome autism, I don't know, but I feel a lot of times it's normal. A lot of times he'll look over and go, and that will strain back and forth, and then he'll periodically start this behavior. It's like, where he's just kind of doing that back and forth, letting all the stuff fall out, the saliva. And I'm like, why is he doing that? Like, so he didn't always do that. So,
Children's saliva are all back and forth to get input into their TMJ joint. So if you're sliding like this, you're getting a lot of information right here. And this joint is the joint that gives you so much feedback in your body. It is the joint where why we overeat, right? Because it feels so good, right? I don't overeat soup, I'll tell you that. I overeat things that I can chew, And so the jaw is really that place, that sensory receptor where if you are not talking and if you are not chewing properly, then you see all those behaviors in the mouth. You see the and you see that this back and forth, and you see pig noises, like those noises. Yeah. Those.
that's because of right?
You see, it's all of that TMJ joint right there. It just needs
He's not getting
input.
what?
He's not getting the input from chewing or speaking that he needs. I
I
know.
thought that was just played, then we had a big joke about it. We
Hilarious.
always.
Yeah. By grinding this way?
So like how do we prevent that if that's our sensory?
Totally. You use chewy tubes. And I will show you them. Use chewy tubes.
What if your kid won't?
Yeah, what if they won't?
They won't like it.
He likes the pee, but that's the only one that he doesn't like.
They use their finger or their thumb. Okay.
Yeah.
Well, okay. All right. Well, I think there are. I think what happens is that you make good tries to try to get some of these in, right? And the difference is you need some maybe overall better direction as to how to get these in. And I'm not saying that it would be a miracle will happen when someone that has some training walks in your door, but at least we could help you move towards the tools. So sometimes children, I have a children I see through Oakland Unified right now who is 9, who would never let anything in their mouth, who just eats purees, right, for 9 years. So we started the program and we slowly got tools up to his mouth, on his face. We worked right below his level of right? And so we got them here, and then you see a little bit in his body and go, okay, that's it for the day. The mom works up to this. And then, the next week we work up, and then, okay, we get there. And then we finally get onto the face, into the mouth. And so we use these programs of scaffolding little by little. And, the end goal is a lot of the same things, and the way you get there is different for a lot of people. So, if your child truly would never take it, I don't have any kid on my caseload that won't take it.
With the first is back one finger. I still play in this one.
So that's not.
But like a page will not have that. Carry that.
Absolutely not. I am not telling you to carry this. I'm not. And this is something I will show you how to use. But this is the last thing I want strapped to your kid. Seriously. I cringe when I see that. It's not functionally appropriate. First of all, there's so many reasons why it's not appropriate. But second of all, when you're using a program, when you're using a Talk Tools program, it is built in hierarchies. And so we use it very specifically. And I would never just say like, here you go, use these, good luck, because that's probably what's been done, or you've been gotten them off the internet. What I do is I will tell you every single thing to do with your child. It is very learning intensive on your part, and it works because we work at your child's level. So sometimes we don't get these in for 3 months, but that child who's 9 now is drinking from a straw, and he's never done that before, you know, and he's starting to eat some solids and starting to talk more. And, you know, so there is definitely hope. Like, I know that these are very common, but they can, when they're used in the appropriate therapeutic way, that's where you see the results.
Like he still needs a shot.
Right.
Are we supposed to try to get that done or?
He needs like a full evaluation, and so that you can know what is right for him, and then you could carry it out at home for him.
But the end goal is for him to be able to manage it at the very end of
When you are,
therapy,
yes.
if he's seeking input to do something more appropriate.
Absolutely. There are children who do seek input, but what you would do is we would find something appropriate, but also when you implement a program like this and you're doing it throughout your day, it decreases the amount your child needs that input. Yeah. Yeah. So it's not a bandage, it really works at the root. Yeah, and that's kind of it. Okay, so let's do this activity. Okay, so when you have, when we talk about your jaw being your core and being really that foundation for support for your lips and your tongue and your cheeks to move, and if you don't have strength there, then all those areas can't do their jobs. When you're talking about that, let's do this chair activity. Everybody put your stuff down for a minute, and let's just do this so you can kind of understand this one. Okay, so sit with your legs out on the floor, your hands on your lap. It's gonna be tight. Okay, so what I want you to do is I want you to first lift your legs, then rotate your feet around, lift them out straight like a pike. Rotate your feet around. I know it's tough. Bummer. Okay, wiggle your toes, like do all those things. Okay, great, pretty easy. Can everyone do it? Okay, all right. Now, front row and people on the sides, come to the front of your chair. Okay, put your legs out. Right, wiggle your toes, wiggle your ankles. What's wrong? Are your toes impaired? Are your feet impaired? Are your legs impaired? No. Your core is not getting the stability it needs. So when you're looking at this and from another perspective, let's say you have freshmen on the bottom, juniors right here, and a senior at the top, okay? You put your freshman on the bottom, this whole thing is gonna come down, right? Because they don't have the experience, okay? You have your senior on the top, and she's amazing. She's amazing, right? And she can do all these things, and she's the best on the squad. She can't do anything if these freshmen are wiggling around at the bottom, okay? The same thing here with these juniors, right? They have great skill, and they want to put their legs up and do their thing, but they can't because these guys down here just joined the squad. And in your mouth, jaw, lips, tongue. Your jaw doesn't have the stability it needs, and stability is so important. If it doesn't have the strength and stability it needs, then the other parts can't do their jobs. So if your jaw doesn't have the stability, then the lips, the tongue, your cheeks can't do their jobs. And when you have proper stability down here, then you have dissociated movement of all your parts. So like in the chair, put your feet back in the chair, you lift your legs up, and you can do all these things, right? You can put your arms out and do like whatever you want. And that's because you have stability here. And so you have dissociation. So my arm can do this, my leg can do this, everything can do whatever it wants to do because I have dissociated movement. You all have dissociated mouth movement. You can speak clearly and you have good dissociation. Our kids, I mean, almost 100% do not have that dissociated movement. Even our greatest talkers sometimes still have lisps, and that, but I mean that those have not been treated. So you need dissociation, which is the separation of movement based on stability and strength. It's so important. And then after that, you can work on grading, which is the refinement of the movement. So like a baby, think of a baby like this, ba, 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 like this. A refinement of that movement is ba, 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 right? And your baby comes, you're spoon feeding your baby and they go like that. That is not so great grading, right? But after a while and after practice, they have better grading. A lot of our kids talk like a mama and go star, and they have all this movement, right? And it's because they don't have the stability. Without the stability, they don't have dissociation. Without dissociation, they don't have grading. And there's a lot of definitions.
Yeah, they don't have dissociation, they don't have what?
Grading.
Grading.
Yeah, so when you have dissociation, then all your parts can move separately, and then grading is the refinement of that, this higher level. And jaw grading is so important for speech sound because if you have poor grading, you do ah and you do e, you can't do anything in between. And then you have poor speech because all of your sounds have a different jaw grade. So like t, d, n has like, let's say a finger, and a finger, a thumb. All of your sounds have different grades that you make them with. And so we have tools that help with that, but it's so important to have the dissociation and then the grading so you practice it into your speech. We just saw fixing is something we see. It's compensatory. I saw a child this week with it, actually. I saw a typical child come in my office, and he looked like this. He had overdeveloped lips, like this, and when he talked like this. This is called fixing, and it's a compensatory posture, and it makes you immobile. What do you think this child is trying to do? He's overcompensating by pulling his mouth so tight because his jaw is so loose. And so he talks like this. And because he has like really defined lips, it's very, when you look at him and you're like, oh, look at those lips. And so we see this in our kids a lot. We see this when they talk like this, when they don't move their lips, they don't move their mouth, they don't really move a lot of stuff because they're just holding tight. It's like if this whole pyramid right here kind of shifted on its side and everyone kind of crumbled together. That's a fixed position. Nobody's mobile. And it doesn't do any good, but it's based on the fact that there's no stability in the foundation.
How else do you know or test to say, okay, well, jaw's so important, you know, like to what degree? How strong is my daughter's jaw? Like, what else would we look for to say, you know, that's actually pretty weak?
From my clinical experience, everybody that's walked in the door has jaw weakness.
But I'm sure it's on the grading.
There
So
is a range, absolutely. Well, you look at the child's speech, you look at their feeding abilities. Are they chewing food? To what extent are they chewing food? Do they have tongue movement, cheek movement, all these things? Some kids have better jaw skill, and so their tongue and lips and cheeks move better. Some children have no jaw skills and no chewing. So you're looking at feeding and speech. I mean, you really need an evaluation to know where your child falls on this spectrum.
So you're saying, don't worry, you would still, no matter what, you'd be looking at jaw.
100%. I don't have any kids that don't have jaw skills. And if you're going to spend time on working on anything, just go there first.
Is it fair to say that if you
see your child kind of their mouth being open, or like I always look for her tongue out, and we're kind of when her tongue comes out from her freaking out.
Yeah.
But if when she's resting, if she's leaves her mouth hanging open, is that fair to assume that she doesn't have enough tension in her jaw to keep her mouth shut, keep her tongue in her mouth?
Absolutely, because your tongue will follow your jaw.
What about they say that the downs have big thumbs?
Well, you know, if you think about a muscle and not being worked, it is bigger. And so when you have more skill at, you know, just like in our bodies, right? When you have more strength and stability, and when you work out more, you get smaller, right? And so with tongues, it's kind of the same thing. Yeah, there are other reasons too, but also your mouth cavity. If your child's tongue was hanging out low during their infancy and their palate formed high, then the chance of having a lot of food in the mouth is not as great. And so then you need palatal expansion, and the tongue can fit in the mouth better. But also you need to work on so many things like airway obstructions, you know, any allergies, all that kind of stuff, and you need to work on the strength to keep the mouth shut.
When seeing somebody like you about our child, we can be able to evaluate that whole piece.
What if most people are
Mouth is closed with the tongue. She's a resting posture of her tongue in your diet. And you need to work on tongue retraction. We'll talk.
For mouth palate expansion, I've seen children that have that and then it's returned or I don't know if you've seen a lot of kids that it stays that way, but that's one of the things that
Not being a dentist, I'm not too sure. I think that's what perhaps some of the other like equipment are for retainers and such after the work, but I don't know completely. But I mean, children use palatal expanders all the time. Yeah, actually will give you more room for your tongue in your mouth. So yeah, it does. It does. How old? Palatal expander. Okay, I have one child whose dad works with all the kids, and she has a palatal expander, and she's maybe 4.
What's too old?
What?
What's too
Oh.
old?
I have kids that have that, and our orthodontist said, like around 13, 15, if you do it at that time, you'll probably have to have a permanent expander because it will be permanent. If you do it earlier, like, and it's started at 8, my non-DS.
Yeah.
Yes.
You know, when you're thinking about a palatal expander too, you also kind of want to plan dental and orthodontic work with your dentist, of course, like when it's time, but also you also want to consider speech and where they are in their speech if you can. Like I have a 9-year-old right now who's just becoming intelligible. And so the second we throw in that expander, it might affect intelligibility. And so you just kind of mentally have to be prepared and ready and, you know, do it appropriate.
Is it true for people who have kids under 18 months that they can do preventative work by spreading?
Yes, and that's why I asked if we have any babies. Do we have any babies 0 to 1 in here? Yes. How old is she? 18? Yeah. Okay. So there is a palatal massage exercise that I teach new parents that very much just emulates what the tongue would do, and the tongue would sit on your palate and you know, hold it wide. And that's why a lot of our kids' palates have raised, is because their tongues hung low when they were babies. And so the palatal massage is really helpful to keep the palate wide. The dentist, my dentist friend, he's so great, he says, your tongue and your palate are married. And if they spend time apart, then they grow apart. And I love that. It's perfect. And the same with your lips and the same with your jaw. So if your top and bottom jaw spend time apart, then this guy stays here and this guy goes here. And so You know, the earlier we get you, the better, because it affects your sinuses, your mouth shape, all the dental work that you don't have to have, you know, your speech formulation, your feeding. It's just, there's so many great reasons medically and for speech and feeding that, you know, and nutrition. If you're not chewing, you're not getting the nutrition you need. So it's just, I'm just in awe. I'm just in awe of the things that we can change these days. We have so many great services now that we did not have 35 years ago, you know, and you see it in our adults now. The good thing about this program is that you can always change them out. And so you can start at 18, and you can have intelligible speech by 20. And so it's pretty awesome. Okay, that's off my soapbox. Okay, let's talk about the speech diagnoses that your child could have. Dysarthria. Every child that has walked through my door has a dysarthria diagnosis because that is muscle weakness. And we know our kids have that. A child that has dysarthria and dysarthria only looks